I would like to briefly introduce myself. As you have read my name, I'm Dr. Uzma, and I've finished my MRCOG, MRCPI, and European Board Fellowship, and one MCA. I don't know are going to appear in this March exam. Can you tell me how many are there who will sit for this exam? Please right here on the chat box.
Ma'am, they said on Feb 1st they will give us a reply, so we all are waiting for that actually.
Okay, fine. Okay, no problem. This presentation is to benefit everyone who will attend, even for the people who are going for MRCOT, because mostly the sessions, most of the guidelines are from the Royal College of Obstetrician Gynecology, which RCPI also follows. So it is to help everyone. To MRCPI, as you know, this is from the college website. The part 2 OSCE clinical examination. It consists of an OSCE objective structured clinical examination and a clinical exam, that is the long. The OSCE has 7 10-minute stations, and there's a 1 rest station in between. The OSCE stations, they test your knowledge, your understanding of obstetric gynecology, following diagnosis, investigation, treatment, clinical, and communication skills. No patient at the rest station, you just sit there and you prepare yourself for the next station. At the clinical examination, that is the long case, you will see either obstetric or gynecology case, and you will have 25 minutes, which will be fully observed. The examiner will be sitting right behind the simulated, seeing you how to take history. Then you will be to perform examination on mannequin, and then once you are done with the examination, discuss the case with the examiner. So can I have the next slide, please? In 2 years we are with COVID. So from May 2021, the examination remains the same, but due to current social distancing restrictions, they have introduced adjustments. The clinical component will be simulated. That is, you will not have a real patient. It will be a just role player. The examination will not be based on, so you will not have a real patient interaction. The clinical examination has a duration of 5 minutes, in which you will be examined by a pair of examiners on a simulated clinical model equipment, that is the mannequin, in either obstetric or gynecology, and you will be asked to change to the format of the OSCE part of the examination, apart from following the social distancing protocols, sanitizing, mask wearing, and reducing numbers and removal of the rest stations. There have been rest station, but still there was a rest station this last exam also. The movement or the examination center to limit close contact. Can I have the next slide? Okay, so every day they are updating things about COVID on their website, but either you should vaccinate it, or you should have COVID test before you go for exam, or approve that COVID within previous 9 months. So if you are fully vaccinated, to show test, you just show them your COVID vaccination certificate. More than enough for you. Okay. What happened on this break? Not hear me?
Voice is cutting, ma'am.
Okay, so what can you tell me? Is it clear for everyone, please? The chat box. So can we have next slide, please? Okay, so before we start with to tell you about the exam, this last exam, which happened after a gap of I think 2 years, it was I appeared in UAE, so I can talk about UAE. Went to Ireland and appeared there. It's the same for them. It started the same. Only the long case because of it started earlier in UAE, and then once it finished in these happened at the same time in both parts of the world. So once you will go for, you will do a long case first. They will divide you into groups, and then you, according to the group, you will go for the long case. In the long case, few lines written in front of you, and there's a role player sitting there, and the examiners are sitting right behind the role player. You have 25 minutes. You don't have a reading time in this, okay? 25 minutes means everything you have to finish in that. So you just read your task and said, okay, I've read the task, and you will start. So you take your history first, your detailed history. Once you finish 10 minutes, there will be a knock on the door. They will pass so that you move to the examination. Then you finish the examination on the mannequin. Then once you're done with the examination, you will go for the discussion about the case, about your potential diagnosis, your management, your follow-up plan. This all will be done in 25 minutes. So once you're done with the long case, there will be a gap. This time there was a long gap of maybe because of the time difference, and then you will be asked to come back for the OSCE. For the OSCE, there will be, like this time there was only one rest station. You might start with the rest station, or maybe in between it will. So in the OSCE, again, the things are just there on the table. There's no separate. You will go, you read the task, and once you are ready, you will just tell, okay, I've read the task and I'm ready for the discussion. So this all will be done within 10 minutes. In the OSCE stations, there will be only one patient, like role play present. Other all will be with the examiner, everything. The role play station, there the examiner will only observe you, how you interact with the role player. This time the role player was a very apprehensive lady, and she didn't allow anyone. She was just continuously talking and talking. Anyways, this was part of her, whatever task was given to her. But this is it. You will have only one related patient in the OSCE. Rest will be all examiners will be there, and they will be asking questions related to the task there. Any questions so far, dear? Please ask me now so that we quickly go through templates and start our session. Everything is clear? Can we go to the next slide? Previous slide, sorry. Okay, great. Have the slide for the obstetric history. Okay, so this is just a general template of obstetric history. Please, whenever you're for a long case, there's a pencil paper there. Write down things. You will forget in the exam. Make sure you write name, age, BMI, which is very important. Before, once exam was in the hospital with the life patient, they used to expect you to know that since when the patient is admitted, they were done in the hospital with the patient. Now it is a late patient, so you don't need to do that, but still you should have this all in your mind. So you history, HI, then presenting complaint, history of presenting complaint. As were in the hospital, have to ask them when they were admitted, whatever was done to them in the hospital stay. Then history, menstrual history, medical history, drug, family history, social. Then you summarize the things to the. Next slide, please. Can I have the next slide? Thank you. Similar history is also the same, only difference that add sexual and contraceptive history in detail and menstrual history in detail. Rest of the things same, and you at the end of the patient. It's a good thing to ask that is there anything that I missed out you would like to add? So she will tell you if you have missed. Role players will help you, so they will help if you have missed anything. Can I go to the next slide, please? Thank you. You always close the consultation by thanking the patient, summarizing the salient points in the history. And of course, the communication key skills, actively listening to the patient, summarizing, posting. Especially when taking history about sexual history or some intimate history, always signpost. Smoking is not something very personal, so no signpost for can I ask you personal questions, do you smoke? This is no, not required. Okay. All right, then we will come to next slide, please. Okay, so there are a few slides now which you might think that they're very basic because most of the are at the postgraduate level working specialists or consultants, but believe MRCPI expect you to know your basics very, it should be on your tips. So although the examination is on mannequin, once you will see that I will perform a general physical examination, speak during the examination. So always what you are looking for in the general examination. So you observe the general appearance of the patient, the state of the nutrition, if the patient is going from the chair to lie down on the couch, so you will see how the patient walks, the level of consciousness, responsiveness of the patient, height and weight, BMI. You look at the hands and the arms. The patient is a smoker, there's tobacco stain finger, club, the vital signs, the temperature. Then you look at the head and neck, the facial hair distribution. If the patient is a case of amenorrhea, then you have to look for the secondary sexual characteristics. Look for anemia, jaundice, cyanosis, lymphadenopathy. Look at the neck for any swelling in the neck, like enlarged thyroid gland. Look for any tremors, and the legs for any swelling. Next slide, please. No, you have to take anything with you. Everything is provided there, so no need to take anything with you. Okay. Right. So then gynecological examination. After the examination, you will perform examination. You will look for distension, any masses, any scars. You will do palpation, look for any guarding, masses. You do percussion, auscultation, and you to distinguish between the solid masses from the bowel or ascites. Then you perform examination, where you need to inspect the external genitalia, perform speculum examination, and then a digital examination. No, you don't have to take anything over here. In UAE, anything, everything was provided there. Okay. All right, can I have the next slide, please? So, examination we already out. There will be inspection, palpation, and there defines the mass and somewhere quota, mobile, what the consistency, solid, paint, you do and then you do auscultation. Since we discussed about gynae cases today, talk about the examination here. Go to the next slide, please. Next slide. Yeah, pelvic examination, anticipation of the vulva. Then you will perform a speculum examination and then a bimanual digital examination. In this exam, there was a plastic cuscal speculum available, disposable one, but you don't have to throw it because they want this to be used for the next candidate. Sorry, and as I told you, that since it is a mannequin, so okay, once you are doing the examination, so you will be looking at the inspection. What you will look at the speculum examination. There is a pap smear also available there, so if required, they will pap smear, and then you will do a bimanual digital examination where about the size of the uterus, mobility, and hematses, cornices, if they are clear or no. So you just keep talking, although you are mannequin. Next slide, please. So this is about the speculum examination. So the speculum, just imitate as if you are in the case. You ask for this gel for it, and then there was an invisible gel my examiner put on my speculum. Then I inserted the speculum. You open the, visualize the cervix, and about how the cervix looks. And then if there is any discharge, you have to collect the swab from there. And then if pap smear is required, you will be performing up. Next slide. Then you perform a manual digital examination. We all know how to perform this examination, but please make sure you keep talking once you are performing examination that you are looking for. Next slide, please. Okay. So this was all about what you're expected to do in the examination, long case. So now we our first station. Do we have people who volunteered and people who agreed to participate and they will perform the station? I'm sure it will be very whoever participates. So we have people who volunteered.
Yes, Dr. Uzma, I'm there. Pushpi here. How are you?
Okay, I'm fine. Thank you. Thank you very much, Dr. Pushpi, for coming forward and presenting this case. I'm sure it will be very useful and beneficial for you.
Yeah. Hope, yeah, it will be sure, for sure. You are such a great mentor.
Oh my God. Thank you so much. Okay, Dr. Pushpi, here, this is the case station. The case station is in front of you. You will have 10 minutes to perform the station. The history is written there, okay? And if you ask, I will provide you with the this one, ultrasound image, okay?
Yeah, sure.
Okay, so your time, put this one now, timer, and you can start reading.
Yeah, sure.
Okay, so we are starting your time. Okay, Dr. Pushpi, is that okay?
Yes. Yeah. Go. I'm almost ready. No worries. Can I see the ultrasound image, please?
Yes, sure. Can you please show us ultrasound image? much.
Is there any labs also or only the ultrasound?
Right now we have only the ultrasound. Just can we go to the station one slide, please? Don't show me this. Just keep it here. Okay, so Dr. Pushpi,
Okay.
here you have this patient, medium,
Yes.
old, and she came in pregnancy with lower abdominal pain and she's unwell, nausea and vomiting. She's married for 5 years. She is nulliparous and took some treatment for product. Before you go to see the patient, this is your discussion between you and your consultant, and you a few questions.
Okay. So
what
can
do
I?
you think? What is your differential diagnosis?
Okay, my differential diagnosis, like I will first present in like a S-bar pattern. So situation wise, we have a 30-year-old with a lower abdominal pain, and her background is Martha Williams. She's 30 and she had an treatment for assisted reproduction. She's a nullipara, married for 5 years, and she's presented now with a lower abdominal pain and feeling unwell and nausea, vomiting. So assessment wise, I would be first doing her examination, clinical examination, taking her observation, taking care of her nausea, vomiting, and keeping in mind that she has a pain. So first I'll comfort her, and then assessment I will do to look for any ascites, or her observations will be taken. And recommendation wise, ultrasound is done, and I will order some labs. Differential diagnosis, which I will keep in mind before ordering the labs, is the most important thing comes in my mind here at the moment is a ovarian hyperstimulation syndrome. And other things could be like other related to hyperstimulated ovary, maybe torsion or rupture of the ovaries or some infections. So here there is fever not given, so unlikely. So these are my differential diagnosis at the moment. Or maybe also ectopic pregnancy. I will keep it in mind, these all things, before I proceed further.
All right. Anything you might like to say?
History wise, I will be taking more in details once she's comfortable about the onset of pain, whether she's able to tolerate orally or not. Is she having any symptoms of shoulder tip pain, giddiness, or any difficulty in breathing, any swellings in the legs? So this will be my another history, and whether she had any history of polycystic ovaries, whether she was diagnosed with that, why was the infertility treatment done for her? Is she having idea about what exactly treatment was given, and whether she has undergone the procedure of egg retrieval, and in that case, how many eggs were retrieved for her? This will be the main, and whether embryo transfer has been done for her or not yet, and does she have any medical problems, any other surgeries for her in the past, and her BMI. If she's a very lean patient, again she will be having more risk for the development of ovarian hyperstimulation, and also allergies, because I will be prescribing her some medications for that. So at the moment in A&E, this will be my quick history with the patient because she's already in pain.
Okay. The next slide, please. Next. Yeah. After seeing the ultrasound.
Yeah, after seeing the ultrasound, the image shows of the ultrasound shows it's a pelvic ultrasound, which shows that there are bilateral hyperstimulated ovaries, and the ovaries looks like around 12 centimeter or more than that, I think one of it, and there is also presence of free fluid. So my diagnosis right now is a moderate ovarian hyperstimulation. Like labs are not done, so I will be like generalize, I can just say that ovarian hyperstimulation syndrome at the moment.
Okay, can you define stimulation syndrome, please?
Okay, so ovarian hyperstimulation syndrome is a complication of fertility treatment, which happens due to the chemicals like HCG and mainly the VEGF release, and it causes release of intracellular fluid into the extracellular fluid. So there is an hemoconcentration, and the symptoms of all the symptoms because of that, like ascites, pneumothorax, and then pertaining to this all loss of intracellular fluid. There is a hemoconcentration and electrolyte imbalance, and later on involving the multisystem.
Okay, so how are you going to manage this case?
So after the quick history and observation of the patient, and I will start the fluid management for her, and also the labs will be sent for her. My labs will be mainly the RFT, LFTs, CBC to look for the hemoconcentration, which will be the hematocrit, and urea and electrolytes I'll be ordering for her, and also CRP, and other yeah, so this will be the main labs I'll be ordering for her. And depending upon the lab, and also never to forget about the venous thromboembolic prophylaxis also for her. And if she's the lab wise she comes as a moderate ovarian hyperstimulation, in that case she can be managed as an outpatient. So I will first wait for the lab, and accordingly I'll decide, but the initial management I will start with the IV fluids, take the weight, abdominal girth of the patient, and yeah, and I'll start the basic management for her.
Okay, so if you're managing her on patient basis, what you're going to tell the patient?
So I will tell her about all the red flag signs, and I will tell her about intake and output, and I will also tell her when she is supposed to come. So if the pain increases, she's unable to tolerate orally, or if there is any swelling in the leg she develops, or if at all there is anything else concerning, like the sudden severe pain she has got. So in that case, she has to immediately come. Otherwise, every 2 to 3 days, it's very important that she comes for the follow-up. And if the embryo transfer has not been done for her, in that case, it has to be stopped, and her the hospital where it is done, her ART procedure, it will be informed as well. And also, if needed, then to the HEFA also the notification will be done by them. So she has to be available every 2 to 3 days, and every visit we will do the labs and also abdominal girth, weight of the patient, and like pain management and antiemetics, and we will avoid the NSAIDs for her. And input output at home also, if she feels that urine color has changed or she's passing very little amount of urine, in that case she has to immediately report to the hospital.
Okay, and when you will admit her?
So admission will be like if the pain becomes worse, or she develops severe shortness of breath, or there is any swelling of the leg which could indicate there is some thromboembolism, or the pain is not improving, or there is a pain score increases, or there is a worsening of her ovarian hyperstimulation in spite being conservative management. So in that case, I will admit. And also if the patient is unable to take orally, and most important, if she is unable to follow up, like she cannot come for regular follow-up, so in that case I will be offering admission for the patient, and if she is in critical or severe OHSS.
Okay, so what are the risks associated with pregnancy and ovarian hyperstimulation?
So there are two types of ovarian hyperstimulation. If the endogenous of HCG comes, then it is pregnancy related, and in that case it will be more severe because the HCG remains in the body, and the pregnancy can worsen the ovarian hyperstimulation. It can be presented as the late ovarian hyperstimulation, like after 10 days, and they can be worsening of the symptom. They can be increased risk of thromboembolism.
Okay, all right. Thank you, Dr. Pushpi. Your time finished.
Thank you so much. I don't think so I could even do the half of the question. Okay,
No,
thank
I
you so
think
much
this
for
is,
giving me opportunity. Thank you so much, Dr. Uzma. It's always been nice to learn from you.
no, always very welcome. Dr. Pushpa, first of all, tell me how you feel, how you performed.
Maybe I could have organized myself more better, but I didn't knew the number of questions coming for me, so I was like not really prepared, not very organized myself. So maybe I need to organize myself more and concise, that I need to finish the questions in 10 minutes. So maybe that could be the only thing I'm thinking about. Because it's like, I think when we enter the exam, we know things, but only thing is, problem is like how to concise and present in 10 minutes.
Tell me what you feel you performed. First, tell me what you did.
Performance, like overall, okay, I felt, but again, like I didn't manage my time well, so I should have been more concise and I should have answered more as per the point instead of being very generalized.
Yes. You performed, you answered most of the questions, but as I said, although I think we know the station, we know the, but once we go to the exam, we just get confused, and then we are not able to answer as required. In MRCPI, what happens is that they don't stop you. They will just give you the scenario and you start to talk. They will only interrupt if there is written in their sheet which is touched or you talked about. So go to the answers for the this one, all the questions. Of course, everybody is saying questions how you will answer all in 10 minutes. I've just added few questions. They did not ask all in the exam. Asking about what is your diagnosis. You have to define your diagnosis and management, and the things which we couldn't come because of the time constraint, is how you can avoid it. Ovarian hyperstimulation. These were the few questions that were asked by the examiners. So you have to in a way that we everything. Okay. So they won't be asking you 50 questions, but of course they will ask about these. We will talk about now. Please, can you show me the next slide? Hello, can I have the next slide, please? Yeah. So as Dr. very rightly defined this ovarian hyperstimulation for us, it is a systemic disease resulting from radioactive products which are released by hyperstimulated ovaries. The strategy of ovarian hyperstimulation is characterized by increased capillary permeability, which leads to leakage of fluid from the vessel. In the third phase, fluid accumulation and intravenously there is dehydration. Abdominal pain, bloating, extreme nausea, vomiting, anuria or oliguria, and patient can be short. You will be able to in front of the examiner. The RCPI people, they are very fond of asking. Okay, next slide. Women are which women are at developing ovarian stimulation. So with PCO, diabetes, previous ovarian hyperstimulation, those who have high follicular luteinizing hormone, stimulating regime, use of GnRH as opposed to the GnRH antagonist, multiple follicular stimulation with high serum estradiol, 20,000, exposure to age trigger or luteal support, or the patient succeeds with the treatment. So these are all at high risk of the hyperstimulation. Next slide, please. So next question which the ask me what are the strategies to be employed to lower the incidence of the ovarian hyperstimulation. How can you reduce using low dose stimulation protocols or natural cycle IVF? You can do follicular monitoring. You utilize GnRH antagonist cycles rather than the agonist cycles. Then utilize progesterone instead of HCG for luteal support. Abandoning the procedure prior to HCG administration and oocyte collection. Delay the embryo transfer following collection and electrophysiology of all embryos. You can do coasting, whereby HCG trigger is withheld until serum estradiol levels they return. And you can do GnRH agonist triggering the final maturation of the oocyte, but pregnancy rates in this case are reduced. Slide, please. So this already answered how you manage the patient in outpatient setting and which patients are to be allowed to go home with proper counseling, with any information regarding their fluid intake and output monitoring. They should be provided with the contact details to access. The state should be avoided. Dr. Pushpi, very good, you cited this thing. Then with severe admitted, and should be offered to them. Good, Dr. Pushpi covered one. All are safe. These all things are written in their answer sheet. So if you talk about them, then very good, you will patient. Then a little more details. No need to talk about these things. Can I have the next slide, please? Very rightly said that 2 to 3 days you will be following in the clinic if the patient is advised to follow patient visits, and investigations will be used to know the degree of intravascular volume. Then which patient should be admitted? Dr. Bush, this answer. Those who are unable to see satisfactory pain control, adequate fluid to nausea, show signs of worsening, or are unable to attend for regular patients, or they have critical ovarian stimulation. Next slide. Then who should provide care to the women for stimulation? It should be for the care of women with stimulation and severe ovarian stimulation, for female hemoconcentration and for dehydrated. Critical ovarian should prompt consideration of unit, and clinician in the management of ovarian hyperstimulation should be the overall in charge of care. Next slide, please. How these women should be monitored? They should be assessed at least once daily if they are inpatient, and more frequent assessment is required for women who are having critical hyperstimulation or those who are with medication. And how the symptoms will be: analgesia and antiemetic, and the medicines is already given, so just avoid the medicines which are contraindicated in the pregnancy otherwise. Next slide, please. They should drink to thirst. Is the most approach to correct dehydration. The women who have having persistent hemoconcentration despite volume replacement with intravenous need drink, and then you need anesthetic input in management of these cases. A diet should be avoided as they deplete the intravenous volume, but they all if they and if all despite fluid replacement and drainage of FPC. Next slide, please. So, do you do paracentesis if there is severe abdominal distension and patient is having shortness of breath and there is the respiratory compromise secondary to the intra-abdominal pressure. There is oliguria, the liquid volume replacement, secondary to the increased abdominal pressure, which is caused by reduced general. Paracentesis should be carried out under, and it can be performed either abdominally or vaginally. Intravenous colloid therapy should be considered for males who have large volumes of fluid removed by paracentesis. Next. Okay, this is covered. The women should be of developing thrombosis. They should be to take low molecular weight prophylaxis. And how long you will continue, this depends upon patient's condition. And what are the worsening signs of ovarian hyperstimulation? Increasing abdominal distension and pain, shortness, tachycardia or hypotension, reduced less than 1000 mAh, or there's a positive balance more than 1000 mAh. There is a rapid weight gain and increase in abdominal girth, and there is increase in hematocrit. So all these signs you need to explain to the patient. So Dr. Pushpi covered all these signs, so that's good. Next slide, please. When is surgical management indicated? It is when there is a coincident problem such as ovarian rupture or ectopic pregnancy. Before and this question also Dr. Pushpi answered that we should be aware of the complications that happen, and if they have not transferred the embryo, you tell them, okay, maybe we will not in the cycle, we will go for embryo freezing, and we can transfer at a later stage. Patient gets on this, having a pre-eclampsia and a preterm delivery. Next slide. Next. Okay, so RCOs already discussed all these. Next slide, please. Okay, so this is how you classify the ovarian hyperstimulation in mild, moderate, critical. I think you know this. So that's all about ovarian hyperstimulation. Any questions?
Thank you so much, Dr. Uzma. It was very nice being presented to you. Thank you so much for your feedback as well.
No, you're always welcome, Dr. Pushpi. Anybody has any question for ovarian hyperstimulation? Somebody is asking how many questions in real exam. So yes, as I said, they don't ask you questions. You just start after looking at the ultrasound picture. This is your diagnosis, how you are going to manage the case. If you don't talk about who are the patient at risk and how you will try to reduce the risk, then so there are about 8-10 questions, but you are able to finish in 10 minutes. Don't worry about that. Okay. Any more questions about this task so that we can go to the next task? Okay, I think everything is clear. So go to the long case. Dr. Nida here, who will take our long case. Nida, you are there? Doctor, if Dr. Nida is not available, can we go to the next OSCE case? If Dr. Shah is available, then we can start the long case later. Please don't show the slides. Go to the station. Dr. Nida or Dr. Shagufta, who is there? Somebody was saying something, sorry.
Ma'am, if nobody is available, you can make use of me, ma'am.
Yeah, sure, Manikam. I think they were with us, but there is some internet issue. Just
Okay,
wait for 2
I will
minutes.
wait, ma'am. Wait, ma'am. Okay, ma'am.
Okay. All right. Thank you, dear. Let's start. Can you write on the chat box if we can start the session with you? Just open your mic and tell us that you are here already so that we can restart session. Let me talk about the long case in the meanwhile. That long case, only a few are written at the one station, and you have to ask everything from the patient. All in whatever you want, if it's the patient will tell you. So everything you should bear in mind. Just maybe 3 lines were written in the long. Okay. Yeah. Dr. Nida, please let us know if you're available. Can you check Dr. Shagufta for the next patient? Okay, so Dr. Nida is joining. Please just let us know once you're here. Anyone want to ask any question in the meantime? Feel free to ask. We will be starting a course if there is exam in March. So we will tell you later about what all will be covered in that crash course. So we'll discuss about that later. Okay, long case is the first one you will do because of the time difference, and the OSCE starts later. OSCE is maybe 3-4 hours after the long case. Depending upon the number of candidates, they divide you into 2 groups. Like our time, they divided us into 18, like 36 people appeared one day. So there were like 18 people who came in the morning, maybe 1 hour before the next people, and then the next 18 came later. So first 18 inside first, and then they will be further divided into, and they will start with the long cases, and once you finish, you go out. Then maybe 3-4 hours later, the OSCE will start, and there is going to be only either obstetric or gynecology. It is next to the hospital, and if you are coming to UAE, then it happened in Latifa Hospital, but not in the hospital like in the gynae ward. It was a separate place in Latifa Hospital where the exam happened. And food, you have to bring your own food. So you have 4 hours at least, where you relax and then come back fresh for OSCE. Okay, Dr. Nida, can we start the session? She is having some connection issues. No, we'll wait for her. Come on, anybody want to ask any questions? Let's utilize this time, dear. If there is technical issue, can we ask Dr. Shagupta to perform the next station? Not this long case. Dr. Shagupta, are you there?
Hello. Hi, Dr.
Yes.
Uzma.
Hi, Dr. Hello, how are you, Dr. Shagupta?
I'm fine. How are you?
Fine, thank you so much. Thanks for joining in and volunteering. I'm really very thankful to you. Okay.
Me should be thankful.
No, Shagupta.
You are giving me opportunity to
It's a
present.
brave thing.
I don't know anything about MRCPI. I will try my
Don't
best.
worry, don't worry. We will tell you everything about MRCPI, and inshallah you will pass in first course. Don't worry about that.
Sure.
The station 3 for Dr. Shagupta, please. Anna, if I can go and have station 3. Okay, Dr. Shagupta, this case, it is the OSCE station, and the station will be written in front of you, and the examiner will be sitting there. So you will have total 10 minutes in which you will read this and perform the station. Okay? There will be no separate reading time.
Okay. In this also we can write down any notes in 10 minutes?
No, there is nothing. It's just a paper where the things are written. There is no paper and pencil provided to you. You just read from there and you start talking. As I told earlier, that in this exam they don't stop you. You just read and you're talking and talking. Unless you have said something, that question only. Otherwise, if you have said so, khalas, you are done. Okay.
Okay. Okay.
Okay. Yes, Anam, if you can go to last station 3. Skip all these slides, go to the last. Dr. Shagupta, can you read the case?
No, I cannot see any screen. Only I can see your video. Nice to see you after a long time.
Yeah, very right. Okay, Anna, can we have station? Yeah, the one.
Okay.
No. Oh, yeah. Can you, Shagupta?
Yeah, I can see now.
Okay. So this is a case-based discussion with the examiner. You will be asked a series of questions related to the case mentioned below. You are seeing clinic, Lucy Williams. She's 30 years old, 3, previously cesarean section, and she's requesting sterilization. Single mother, non-smoker, is fit and well. Okay, so you don't the patient, you are interacting with the examiner. Okay, so I'm starting your time now.
Okay. So this is now started 10 minutes, no 2 minutes, anything like that to prepare?
No 2 minutes. Your time has already started. Okay.
All right. Okay. Okay. So I have read the scenario. I am ready for the discussion.
Okay. tell me an SBAR pattern.
Okay, so this is this lady who is Lucy William. She is 30 years old, and she's requesting for sterilization. She's para 3. He's having a history of previous cesarean section, and she is a single mother and non-smoker, and she's fit and well. So I would like to assess her. I will take further information from this patient, and we'll do a clinical examination and will plan a management plan.
Okay. So what you will do first? You will go to the patient. What you will talk about with the patient?
Yes, I would like to introduce myself, and we'll check the patient identity, and then we'll ask further information from the patient. First of all, I would like to know what is the reasons behind the sterilization, why she wants the sterilization, whether she has decided already, and whether she knows about the sterilization, what is the benefit and risk. So I will explore about the sterilization's reason. Then I would like to, in the history, I would like to take a detailed history that this patient, that she's a single mother, and she has 3 children. So I would like to previous 3. So I would like to know about her previous, whether the children are alive, or whether there was any issues during the cesarean sections previously. And also I would like to know more about whether she is in, since when she is a single, whether she is in any relationship or not. If she is not in relationship, so what is her wishes for the future? Whether she would like to have any partner currently in recent, because it will affect her the choice of maybe she wants to get pregnant later on. So I would like to know more about her fertility wishes. Then I would like to know more about her, whether what's her last period date, whether maybe she's already, I would like to know more about her last period, because it will also affect her, whether she is in that ovulation period or not. And also I would like to know more about her smear history, because she is 30 years old. So what is her previous smear test? And then I would like to know about what contraception she is using. Although she is single, whether she is maybe she's having some other partner or not. If she is having partner, so whether she is having any contraception or any history of sexually shared infection she had in the past. All this I would like to know in the history. Then medical history is important, whether she is epileptic or not, or whether she is taking any drugs for any medical condition. Although she is fit and well, but still I would inquire to confirm it. And allergies, whether she is allergic to anything. And she is non-smoker. And what is her weight to height ratio, BMI, important. Because this will affect her, because she's going for a procedure. So it's very important to know her risk of the surgery. And then the family history of what is the support, whether she's who is financing, and who is what is the background. And this all I would like in the history.
Okay.
Then,
so I will tell you about history, as she's a single, but she's actually active. Right now she is not taking.
I could not hear.
Can you hear me now, Dr. Shah?
Yeah, it's voice is breaking. Yes, what you told?
Okay. She is sexually active, currently not taking any contraception, and she is very adamant that she wants sterilization. Okay. So what else would you like to offer?
Okay, so I would like to offer her, because this is, I would respect her wishes, but I will explain her other option as well, other alternative options, that in her young age, there are, I would discuss with her the detailed counseling of sterilization versus with the other options available. And also we'll discuss the benefit and risk of each option. So in the sterilization, I will explain her This is a permanent method of sterilization, and I will discuss the failure rate is 2 to 5 in 1,000 procedure, and there is a regret, and it will not be, maybe it will not be reversed if she is planning for having further children. So the reversal will be very difficult. So I would discuss all this with the patient, and will also explain about the risk, that in view of her, the risk are in relation to her previous 3 cesarean section also, and also the risk itself of the sterilization, if it is done by the laparoscopy as well. So risk, there is an increased risk of injury because of increased previous cesarean scar adhesions. And I would like to discuss with her the injury to the bowel, bladder. Will explain her first the less common risk, then the frequent risk, and the serious risk. So there is a risk of bleeding infection, and there is a maybe failure to gain entry because of scar formation, and maybe failure to complete the procedure. And also there is a risk of, if she gets pregnant even after sterilization, so there is a risk of ectopic pregnancy. So this all I will discuss. And also the failure rate is the same to 1 in 200 with the laparoscopic sterilization. And as compared to other options like long-acting reversible contraception, that is the intrauterine contraceptive device, these are all suitable in her age group and in view of her previous cesarean sections. So this is the most safest in her situation. And this is the copper T and the Marina and the progesterone. This is Depo-Provera. So this we'll discuss, and also I will discuss that sterilization procedure will not prevent her from sexually shed infections, but she has to take the condom as well if she is sexually active to prevent the sexually shed infection.
Can I
Sorry?
Next slide. Okay, you already. Okay, can now anything else to add in the history, or what you will offer?
I will tell her that the other long-acting reversible contraception is more effective, less failure rate, and less risk of surgery and anesthesia. So we'll just discuss and take the informed consent from the patient that what she's choosing. So we'll respect.
You already know the type of you will take. So can you tell me the different techniques of entering abdomen with the laparoscope?
Sorry?
What are different techniques of entering in the abdomen laparoscope?
Yes, there are entry technique. It is a closed technique and it is the open technique. The closed technique is when we are the palmers, when we are using the Vadis needle, and the other is the Hassan technique and palmers technique.
Okay. What points of entry into abdomen?
Sorry?
What is the alternate point of entry into the abdomen if you are not entering?
I'm not hearing you.
Can you hear me, Dr. Shakur?
Yes, now I can hear you.
Yeah. What is the other point of entry into the abdomen if you are not entering through umbilical?
Yes, one is the supra, below the supra, in the line of the supraclavicular region. This is we call the Hassan technique. Sorry, this is the Palmer's technique, which is 2 centimeter above the this one. This one we are using for the when there are the cesarean sections. So there is an increased adhesions in the midline. So that's why we are using this technique. This is the entry for at that point.
Okay. What pressure will you maintain at the entry during the procedure?
initially it should be 20 to 25 millimeter of mercury while entering the chukar, before entering the chukar. After we entering the chukars, after secondary chukar, we reduce the pressure to 12 to 15.
Okay, your time to ask you this question. What you told me some complication laparoscopy.
Complication of laparoscopy, that is a uncommon risk, bleeding, infection, wound, gapping, and the injuries to the bowel, bladder, and ureters. And the serious complication could be the death, and also failure to complete the procedure, and extra procedure in case of hemorrhage, the blood transfusion.
Okay. Thank you very much, Dr. Shagupta, for
you.
the performance session. Now about how you perform.
Laparoscopy, I did not revise for long.
It's okay. Tell me well in your station.
I don't know. You will give me the feedback.
Yeah, I will give you the feedback, but you must know what are your good points.
I tried my best.
No, I think you performed very good, Dr. Shagupta. You almost covered everything.
Really?
You answered almost. Yeah, you have the station. You need to organize yourself a bit, and that is all. You passed this. Okay. So it was a easy problem. Can I have the next slide, please? Okay. So actually, in this station, what they are expecting you to talk about is to start with the long-acting reverse contraception. You have to offer the patient, first ask what contraception is taken, ever tried any form of contraception. You already spoke about the failure rate, but you have to compare the failure rate between long-acting reversible method and the permanent method. And just one more thing, that this reversal will be covered by the, it will not be funded. You have to do payment if she goes for the future. Then you spoke about the new partner and more children in future, so this should be highlighted in your consultation with the patient. This thing is normally there is a lot of regret associated with the permanent method at a younger age. The patient should be counseled contraception. The other thing they were expecting in the station during the exam was that if the patient is adamant to go further, then you can always take consultation with your consultant. And if he still decides to go for the procedure, then of course you have to for her, you have to respect her wish. Okay. Once you are done with this, then they will ask what type of consent you will take with laparoscopy. So first, once you will talk about the long-acting reversible and inject. Then you also have to speak about the okay. This reversible method. Next slide, please.
Your voice is breaking.
Okay, can you hear now?
It's audible, but in between it's breaking.
Okay, I think anyway, signals are full. Excellent. Anyway, all of you can hear me, please.
Yes.
Okay, then they were. Okay, that's great. So was about what is the failure rate. She asked me, Examiner asked me about failure rate of. Okay, so you know, IUD active, you can keep it from 8 to 10 years. Then there is Marina for 3 to 7 years. Implant for 10% effective. This injectable special method. She asked about the failure rate, and she asked about the failure rate of sterilization also. Please.
Dr. Uzma, this is according to Ireland guidelines, or this is somewhere we can use only anyone?
It is general guideline. It is all. There is no specific Irish guideline. Okay, whatever is appearing SRH, you have to follow that. Okay.
Okay, research. Okay.
Next slide, please. Okay. Then, Doctor, you cover in the consent where you will write the procedure or treatment, and you will document the findings, including describe the nature of laparoscopy as described in the information leaflet, and what other procedure might be anticipated laparoscopy, what are benefits and what are the significant and serious risks. Next slide, please. We should tell that over risk of serious complications, diagnostic laparoscopy in general is telling you this is 1,000. It can be damage to bowel, bladder, ureters, blood vessels, which should require immediate laparoscopy or laparotomy. However, up to 50 bowel injury not the laparoscopy. Failure to gain entry, these also are covered. Of hernia, any complication is very rare, and which is 3 per 1,000 is very, very rare. The frequent risk, Dr. Shagufta, bruising, short pain, wound bleeding, and infection. Can you hear? Is the voice clear now? Next slide, please. Can you all please? Hello. Am I audible?
I think, Dr. Uzma, if you can join again, so perhaps, it will be good.
Okay, okay. I will
Yes.
come again. All right.
Hi, Ruchi. How are you? Okay, that's great. So I believe you are preparing for MRCPI as well. So that is a good
Am I
thing.
audible now, girls?
Yes, yes, you are. Perfect. Now it is okay.
All right. So where were we? Okay. So we were talking about the consent of laparoscopy. Any extra procedures which may become necessary during the procedure, it might be laparotomy if you have done some damage to the bowel bladder, so that needs to be repaired, or blood vessel, and patient might need blood transfusion. What the procedure is likely to involve, the benefit and risk of any available alternative treatments, including no treatment, and statement of the patient. procedure which should not be carried out without further discussion. If there's something which patient says, no, if you even find this, don't do it. So it should be documented on the consent. Then pre-operative information, a record should be made of any source of information. Anesthesia, anesthetic should see the patient. And where relevant, the woman must be made aware of the form of anesthesia planned and be given an opportunity to discuss this in detail with the anesthetist before surgery. Next slide, please. Okay, so how should women be counseled prior to laparoscopic surgery? Women must be informed of the risk and potential complications associated with laparoscopy. This should include discussion of the risk at the entry technique, specifically injury to bowel, urinary tract, and major blood vessels, and later complications associated with the entry ports, specifically hernia formation. Surgeons must be aware of the increased risk of women who are obese or significantly underweight, and in those with previous midline abdominal incisions, peritonitis, or inflammatory bowel disease. These factors should be included in patient counseling where appropriate. Then the next question, as I think Dr. Shagufta, you were confused between Palmer point, Hassan technique, open technique. So this is all there available in the RCOG guidelines. We follow that. The gynecologists, they have tended to favor the closed or very needle entry technique, whereby the abdominal cavity is insufflated with carbon dioxide before introduction of the primary procar and cannula. The surgeons, they like to do the Hassan open technique. So you will say the answer is that open technique and closed technique. Okay, this was the answer. Next slide, please. No need to know, yani it is good for you to know this for your own information, but they were not asking about this. But they will ask you about how you will enter the abdominal cavity with the Veress needle. So the Veress needle should be sharp with a good and testing spring action. Disposable needle is recommended as it will fulfill these criteria. The operating table should be horizontal at the start of the procedure. The abdomen should be palpated to check for any masses and for the position of the aorta before insertion of the Veress needle. The lower abdominal vein should be stabilized, abdominal wall should be stabilized in a way that the Veress needle can be inserted at right angle to the skin and should be pushed in just sufficiently to penetrate the fascia and the peritoneum. You should hear 2 audible clicks as the layers are penetrated. Then excessive lateral movement of the needle should be avoided, as it may form this small needle point injury into a bowel or vessel complex tear. Okay, next slide. Then this pressure, you should know. Dr. Shagufta answered this question very nicely, that entry, how much pressure is required, and then inside how much pressure is required. And why you choose umbilicus? Because it is the thinnest and most consistent area on the abdominal wall. The peritoneum is firmly adherent to the underlying fascia. It's less vascular, and for the cosmetic reason. And how you will check if it is intraperitoneal? This also she asked. So you will perform a Palmer's test, a syringe containing normal saline. You just have to know what things you can test. So no need to explain how you will perform Palmer's test. Just say Palmer's test. That will be more than enough. Next slide, please. So this was the intra-abdominal pressure. This was the question, how much pressure is required at the entry, 20 to 25 mmHg of mercury. Distension pressure should be reduced to 12 to 15. This also was asked. If you are not staying by yourself, she will ask how much pressure at insertion, and then later how much pressure is required. Next slide, please. This already we answered. Alternative entry technique. This is the Palmer's point. Okay. Then this was also asked. Next slide, please. And then how should secondary ports be inserted? They did not ask this. This is only for your own information, that secondary ports must be inserted under direct vision perpendicular to the skin while maintaining the pneumoperitoneum at 20 to 25 mmHg. During the insertion of the secondary ports, the inferior epigastric vessels should be visualized laparoscopically to ensure the entry port is away from these vessels. During insertion of the secondary port, once the tip of the trocar has pierced the peritoneum, it should be angled towards the anterior pelvis under careful visual control until the sharp tip has been removed. Secondary ports must be removed under direct vision to ensure that any hemorrhage can be observed and treated. And yes, if the woman who is obese, what specific measures are required for obese women? Open Hudson technique or entry at Palmer's point are recommended. This also was a question in exam. For the women who are morbidly obese, if the Veress needle approach is used, particular care should be taken to ensure that the incision is made right at the base of the umbilicus and the needle is inserted vertically into the peritoneum. Then if the patient is thin, this was also a question that the Hudson technique or insertion at Palmer's point is recommended for the primary entry in women who are very thin, and women at highest risk of vascular injury are the ones who are young, thin, nulliparous with well-developed abdominal musculature. And the females who are with severe anorexia, they are also at particular risk. Next slide. Okay, come back to now station 2, please. Dr. Nida, do we have you here now? Any questions about this station, please? Feel free to ask.
Dr. Uzma?
Yes, Dr. Shagupta.
Yeah, I want to ask regarding this case-based discussion. There will be 6 stations?
There
Or
will be 7
total?
stations. 7.
And so what is the role player, like simulated patient, that is, it is only long case? That
No.
In which...
There is, like this time, there was one role play station out of these 7 stations. Long case is separate. Long case is with a simulated patient. Okay. In the OSCE stations, although they told there will be one labor ward prioritization and one clinical skill type of station, but it was not there. Out of 7, only one was a simulated patient, where one patient was sitting and she will talk and you have to answer her questions. That's it. Rest of 6 were with the examiner.
So there will be no any time in between 2 stations?
No, there is hardly a few minutes where they will, maybe 2 minutes they are giving, but you are not, this is not your reading time. You are just finishing the station and getting up and, standing on the side for the next station. This is for the examiner to finish marking the previous candidate.
And in this CBD, there is how many maximum question or minimum questions they will give? How we will know? Like we will be seeing outside, or this will be only in the examiner paper? How many questions will be there?
Actually,
how will
this time, what happened, there was no mark sheet in front of you. Like examiner was not holding any paper. Only this station was written in front of you. It was lying on the table. And maybe they already have read everything or what, they don't see that. But they know where to stop you and what you have missed. So they will ask if there is still time. Or if you are going here and then they will bring you back on the track, what they want to know out of you from this further station. Okay?
So question will be visible in front of us, right? How many questions are there?
No. Nothing will be visible. Only the station. These 4 or 5 things will be written. That's it.
So they will ask from their side.
Yes, they will not ask. That's what I told you. If like this ovarian hyperstimulation, I don't know if you were there or no, when Dr. Pushpi presented. Were you there?
In between, I was not there.
Okay. So the station is written only what is the case, and if there is ultrasound available, that ultrasound will be provided. Now you will start talking about it, okay? And then if you are stopping in between, then they will ask you questions. If you are answering whatever they expect you to answer, you will just continue. They will not interrupt you.
So how we will time our station, because we don't know how many questions are there. We will talk in one point and there is other question also. Like
There is
you
a
asked
lot of
me in
time, Mr. Gupta. There is a lot of time. Don't worry about the timing. Once it is a case-based discussion with the examiner, always you are finishing before the time finishes. Don't worry about that. You just
So we
need
should
to talk.
continuously talk, right? We should continuously
Yeah.
talk. We should not take pause like MRCOG that they will ask
No.
next questions, not like that.
No, it's a bit different from MRCOG. You see, in MRCOG, the marks are distributed in several places with the patient safety, communication skill, and this and that. Here, it is more knowledge-based exam. If you know the topic, you can easily pass the exam. But your communication skill and other things are not tested that much here. Your knowledge is tested, so you should know the topic. This is very important in our RCPI.
Okay, yeah, that's good. Okay, thank you so much.
You're welcome, Dr. Shugupta. Okay, I think Dr. Nida is having some internet issues. Anybody want to volunteer for the long case?
Ma'am, shall I, ma'am?
Yeah, sure, doctor. No problem. Okay, so before we start this long case, I will just tell you that you will have this information over here, and rest of the things you will ask from the role player, and I will be your role player and I will be your examiner. Okay?
Yes, ma'am.
Okay, so you have 25 minutes to perform this station. Okay?
Yes, ma'am.
Okay, let me just put your timer on. Okay, Dr. Manikam, can we start?
Yes, ma'am. Hello. I am Dr.
Hello.
Manikam, doctor in clinic today. Shall I confirm your name and age, please?
Yes, doctor. I'm Tanya Williams and I am 76 years old.
I came to know from your GP's letter that you got some bleeding down below. Am I right?
Yes, doctor. I don't know what happened. For past few months, I'm having on and off bleeding. My periods stopped long time ago, but I don't know why this bleeding is starting. I'm really very worried about this bleeding.
I'm able to see that you're in distress. Before that, shall I ask you a few questions to know more about you? And we'll run some investigations, tests, and I'll want to examine you in presence of chaperone with your consent, and then we can discuss and come to a mutually agreeable management plan. How does it sound?
That's okay, doctor. Fine with me.
How can I address you?
Tanya is fine, doctor.
Tanya, please tell me about your condition.
Yes, doctor. As I told you, everything was fine for before 6 months, but I just started to have this bleeding from down. Sometimes it is more like a period, sometimes it is just a spotting, but it is really bothering me. So I went to my GP and they just sent me here.
Did you undergo any tests there?
They performed one ultrasound for me, doctor.
The down below?
Yes, from down below.
Do you know any findings of that scan, Tanya?
Yes, doctor. They told me that, I don't know, endometrial thickness. They told me it's increased. It is 24 millimeters. And rest of the things they said it's normal. My uterus was normal in size and the ovaries were not visualized. There was nothing else seen during the scan, just increased endometrial thickness.
When did you attain your menopause, Tanya?
Oh, that's a long time ago. I think I was 53 years at that time.
Okay. Have you ever had hormone treatment after that?
No, doctor. I prefer not to use hormone replacement. No.
You are already 72 years. Please don't mistake me. are you with someone?
No, I am alone.
No. Okay. Have you ever been treated for any in before menopause? Have you been ever treated for a sexually shared infections? This is some
No.
including questions. Okay. Were you up to date with your cervical screening program?
Yes, I was up to
Okay.
date and they stopped. Everything was fine.
Is there any pain in your tummy or any increased size of your tummy or any loss of appetite, loss of weight?
No, doctor. Little pain only, but nothing as such. No loss of appetite or loss of weight.
Okay. Any swelling of the legs? No.
No.
And do you have any medical condition for which you are being treated by your GP?
Yes, doctor. I am diabetic and I am on oral medication and insulin.
You are under control? Are you?
Yes, I am under control.
You are compliant with the medications.
Sorry?
You are continuing your medication adequately.
Yes. Yeah.
Are you allergic to any medication?
No.
Do you have you ever undergone any surgery in the past?
No, doctor.
How many children you have got?
I don't have any children, doctor. I never got pregnant.
Did you have any history of PCOS? Polycystic ovarian syndrome? No.
No.
Your periods are regular?
Yeah, they were regular.
Okay. Any family history of this cancer, the cancer of the womb, cancer of the ovary, or cancer of the colon?
Yes, my mother, she died of cancer of the colon and no other cancer in the family.
Any family history of clots you have?
No.
Are you aware of your weight to height ratio, Tanya?
Yes, doctor, it is 43, my BMI.
Have you tried any treatment to reduce your weight to height ratio? Any physiotherapy or diet like that? Did you ever been advised by a GP for that?
Doctor, at this age, I don't want to try anything.
Okay.
I just want to live my life now.
I respect your wishes. Are you aware of your blood group?
Yes, it's O positive.
Do you have any reservation for blood transfusion?
No.
Okay. About your personal habits, do you smoke?
No, doctor.
And you never consume alcohol, no?
Occasionally.
Occasionally.
Not, yeah.
Previously, you ever had the habit of taking drugs for recreation? This is an intruding question, sorry to hear. To ask
no,
you.
doctor. No.
You are well supported in your family?
I run my own business.
Okay. Do you feel down, depressed for the past 4 weeks?
No.
Do you want to add anything else?
No, doctor, I think you've asked everything. Just my ultrasound was done and I already told you about my findings. Thank you.
Do you feel any tiredness, nothing of that sort?
No, I just feel anxious because of this bleeding.
Okay.
Nothing more than that.
I want to examine you in presence of chaperone with your consent. My staff nurse will record the blood pressure, heart rate, and temperature. I will examine your tummy for any mass, or any fluid in the abdomen, and I will examine you from down below to have a look at the neck of the womb and I want to do an internal examination in a gentle manner to look for any mass in the pelvic region.
Okay. So, Dr. Manikam, here you will finish with the patient. Now the examination will be on the mannequin.
Okay, ma'am.
Okay. So now, what would you like to see in general physical examination?
I want to see whether the patient is anemic, and I will record the blood pressure. I want to examine for any lymph node swellings in the inguinal region. Then abdominal examination for any mass, any free fluid in the abdomen, any tenderness. And then speculum examination to have a look at the cervix. And then I want to do a bimanual pelvic examination to find out the size of the uterus and any mass in the adnexa.
Okay. General physical examination is normal. If you can see in the station, it's written her blood pressure is high, 150/90. Otherwise, there is no swelling, no anemia. Abdominal examination is unremarkable, and the general examination is a normal size uterus, freely mobile. It is clear. Cervix looks normal. Anything else?
Tanya, Salma, Tanya, with your findings, next we have to do some tests. That is, we have to do a tissue sample from your inner lining of the womb. That can be done by as an OP procedure also. If you are willing,
Okay.
we'll do the
1 minute, Dr. Manikam. 1 minute, Dr. Manikam.
Okay.
You have finished with the role player. You no need to explain anything to the role player. Now you are with the examiner.
Yes,
okay. So what is your next step in the patient management?
Ma'am, I want to do a pupil sample, endometrial sampling, and get the histopathological examination, ma'am. It is 99% effective. I mean, sensitive to find any. Already the endometrium is very thick. It is 24 millimeters, and she's not on any medications like tamoxifen. So I want to rule out endometrial hyperplasia with atypia or endometrial carcinoma, ma'am. And if
any other investigation you would like to?
And then if it is positive, I will ask for an MRI of the abdomen and pelvis, X-ray chest also, and I'll. I mean, the patient will be, if endometrial cancer is diagnosed and the histological grading, if they are able to find out, I'll refer the patient for MDT, it is MDT specialist team with the oncosurgeon, the consultant, and the oncologist, medical oncologist, and the radiologist. They will, her details will be sent to them, and they will discuss about her condition and the extent of the endometrial cancer, whether it is extending to the full thickness of the myometrium, or it is involving the serosa, or whether it is involving the adjacent structures, any lymph nodal involvement, everything can be diagnosed preoperatively, and she will be prepared with she'll be discussed and discussing the risks and the benefits of the surgery, and after controlling her blood sugars and her BP and whether other blood tests, full blood count and X-ray test, and the physician and anesthetist will examine her, and if she is fit, she can undergo keyhole surgery, as she is very obese and she is not willing for any. If she is willing, if she can be convinced by the team of doctors, MDT, she can undergo bariatric surgery to reduce the BMI. If she is not willing, she can undergo surgery, laparoscopic TLH, ma'am, total laparoscopic hysterectomy, the bilateral salpingo-oophorectomy, and the staging of the disease will be done. If any nodes are palpable, they will be removed, and post-operatively, that entry may be through the Palmer's entry or open technique may be used, or there is a risk of converting it into open laparotomy is also there. Everything should be discussed to the patient, and the risk of clots, everything is, risk of VTE, everything to be discussed with her. And then we are operating, and then the sample is sent to the histopathologist. And after that, the discussion will, again, the MDT will be oncology MDT team will discuss about the if the myometrium is also involved more than 50%, she may need post-operative brachytherapy, ma'am. Then she'll be followed up every 3 months for 2 years, first 2 years, then every 6 months for next 3 years, then annually, ma'am. These, if she belongs to the stage 1, that is, if it is confined to the endometrium and less than 50% of the myometrium, she has a good prognosis, and her 5-year survival rate will be 95%. That will be best. And post-operatively, she should be given antibiotics and early mobilization. Then I'm going here and then there, ma'am, please forgive me. And she has to be given thromboprophylaxis for 6 weeks, ma'am. Sorry, 28 days, ma'am. Sorry, ma'am, 28 days, ma'am.
Okay. Anything else, Dr. Manika?
We should look for the report may say if there is a associated tumor in the ovary, estrogen secreting tumor, can be a granulosa cell tumor. The possibility is also there. That's
Okay.
all I know, ma'am.
This is once they performed endometrial biopsy, they found it is type 1 cancer, endometrial cancer. So what is your treatment? You already told me about the treatment. You reached till the end before I asked you any questions. So can you perform this? You told me the treatment. What is the treatment?
Total laparoscopic hysterectomy, the bilateral salpingo-oophorectomy, ma'am.
Okay. And you told me already about the follow-up plan. Anything else, Dr. Manikam, you want to add?
The uterus is of smaller size, ma'am. If it is so big, you can think of any uterine sarcoma or other rare cancers. If it is there, she has to be followed up by the CT scan of the chest, and she may need chemotherapy and all, ma'am.
Okay, you still have 8 minutes with you.
Then post-operative prevention of VT is the highest risk, and post-operative complications, she can develop a vault hematoma. So she should be looked for any risks of surgery, risks of laparoscopic surgery, injury to the adjacent bowel, bladder, ureter, and the blood vessels. And Hassan's technique also can be used for her. And then these risks are 2 in 1,000. There is a rare risk of death due to venous thromboembolism and pulmonary embolism can happen. There is about, I don't remember the percentage now, and she can have infection, bleeding, and vault hematoma leading to sepsis, and urinary tract infection can occur. And increased, I mean, in the postoperative period, she may have retention of urine or stress urinary incontinence. These all can be treated, ma'am. As she is a diabetic, there is a risk of vault hematoma getting converted into pelvic abscess, so she has to be given broad spectrum antibiotics.
Okay, what are the risk factors in her case for endometrial cancer?
She's obese, ma'am. She's having comorbidity, that is diabetes. Hypertension is also there, and she's a nullipara, and family history of carcinoma colon is there. So if possible, we can do, I mean, the genetic study can be done to rule out any Lynch syndrome.
Okay. Anything else, doctor?
If she develops any, she's already post-menopausal, ma'am. There's no need for hormone therapy and all. She will not develop such condition. If she is already attained menopause some 20 years ago, there is no need for post-menopausal therapy and all. She needs a support and rehabilitation to be, and early mobilization, everything, and good support from the family side should be provided, and support groups and psychosexual counseling to, as she has undergone a major surgery with this so much of comorbid conditions can to be followed, ma'am.
All right. Is that all, Dr. Mahika?
I don't know, ma'am. Whether I have left, but I was wandering here and there. Sorry, ma'am.
No, it's okay, doctor. So we are still 5 minutes, but I think you have covered everything. So we will stop here. And okay, well, how you think you performed, doctor?
And that's how I feel, ma'am. I'm going here and there. I'm not in organized.
What you performed? How did it go? What went well?
I was able to. I was able to elicit the history well, I think, ma'am. I don't know. You have to tell the feedback, ma'am. And I was able to tell the investigations also. And I said the MDT should include the diabetologist and the physician. She should also, for this age, she should also undergo the cardiology evaluation. Echocardiography may be required for her.
Okay. Okay. Dr. Manikam, I think you performed very well.
Thank you.
Covered many things, most of the things in history. Only just you need to be organized a bit. You were going here and there, and you were not asking things from the patient too much. You are not involving the patient in your communication. So this needs to be addressed. Her blood pressure is written, so you did not, address blood pressure. Till the end, you did not ask if this is the first time her blood pressure is high or something happened. You did not talk about that at all. So anyways, in the exam, it was a simulated patient task. The patient sitting, because even the age was not mentioned, the patient was 76. So it is, she was all by herself. Once I asked the patient, what do you do for living? So first she said, I work in a beauty parlor. Then maybe immediately she realized that she cannot work at 76 in beauty parlor. Then she said, I own the beauty parlor. Then she was all by herself. So you have to address the 76 years age, what sexual counseling she will need.
Yes, ma'am. I should not ask that.
Yeah. So, once you are taking history, you have to tailor the history according to the patient age. And no need to, just go with whatever you have learned for the normal gynae history
template.
Template. You have to modify it as per the patient, as per the history. This is very important. Okay. And then once I stopped you over there, once you finish with the patient in the exam, once you finish with the history, you are not supposed to tell anything to the patient, okay? She don't want to know. The examiners are already observing you. So once you said, okay, I would like to discuss the case now, so they will say, okay, now you will discuss with us. So they will ask you, what is your diagnosis? So you told me that your diagnosis is you are suspecting this and this. So you have to give me a differential also. What are the other possible causes of post-menopausal bleeding? Okay, not only endometrial cancer, what else can be there?
Okay, okay.
Okay, what other investigations?
I should tell about atrophic endometrium. That is the most common cause, like that.
Yeah.
Do you mean that, ma'am? Okay, okay, ma'am.
Yeah, they want some more differential diagnosis, no? So in age of 76, there can be atrophic vaginitis only, which is causing bleeding, right? So you don't have to go directly only endometrial cancer, since you know the endometrial thickness. Go for the common things first and then go for the rare things, okay? So anyways, it was a very well performed station, very well done, Dr. Manikam. You passed the station for sure, but you just need to organize yourself a bit, and we will just talk about endometrial cancer now. Can I see the next slide, please?
Thank you, ma'am. I need the practice and guidance of mentors, ma'am. Thank you, ma'am. Thank you so much, ma'am.
You are welcome, Dr. Manikam. It is just a matter of practice. Your knowledge is there. You just have to organize yourself. That is all. Okay?
Yes, yes, ma'am.
All right. So here are the causes of postmenopausal bleeding. Most common is atrophic vaginitis, 60 to 80%. Then estrogen treatment, 15 to 25%. Any polyps or endometrial or cervical, this is 2 to 12%. Endometrial hyperplasia, which accounts for 5 to 10% of postmenopausal bleeding. Then endometrial cancer is 10%. And in 10% cases, no cause is found. Next slide, please. So this is again same. If you are just looking at the uterus itself, then atrophic endometritis causes 30% of postmenopausal bleeding, polyps 10%, fibroids 10%, hyperplasia 10%, and malignancy is 10%, and miscellaneous is 30%. Next slide.
Yes, ma'am.
As we know, this is the most common gynecological malignancy in high and middle income countries. The overall prognosis is relatively good, but high-grade endometrial cancers, they tend to recur. Recurrence needs to be prevented since the prognosis for recurrent endometrial cancer is dismal. Treatment is tailored according to the tumor biology. This should be the optimal strategy to balance treatment efficacy against toxicity. Next slide. So hyperplasia, endometrial hyperplasia covers a range of pathological changes in the uterine glands and stroma. It can be simple or complex, with or without atypia. The presence of atypia is the most worrisome feature, as approximately 20% of those with atypical hyperplasia will have a concomitant endometrial carcinoma, and a further 25 to 30% will develop endometrial hyperplasia within the next 2 years. Next slide. So risk factors, doctor, very rightly you spoke about obesity, nulliparity, and other family history of cancer. So she has 3 risk factors in her history. She was obese, she was diabetic, she was nulliparous, and there was a family history of colon cancer. Okay. Other factors included are early menarche and late menopause, unopposed estrogen therapy, and functioning ovarian tumors, previous pelvic irradiation. Okay, next slide. The patients who are at higher risk are the patient with Lynch syndrome, the patients who are taking tamoxifen, patient with PCO, and patients with obesity. Very nicely you asked me about PCO. Very good, Dr. Manikam. Next slide, please. Next slide. Okay, there are certain protective factors like use of hormonal contraception. They reduce the risk of endometrial cancer by 30 to 40%. Multi-gravidity, and the more children you have, this reduces the risk of having endometrial cancer. And older age at last part also reduces the risk. Childbearing at an older age, independent of parity and other factors, is associated with a decreased risk of endometrial cancer. Breastfeeding is protective. And smoking is also protective for somehow. They say that the mechanism is suggested for this effect is smoking stimulates hepatic metabolism of estrogens, which leads to reduction of incidence of endometrial abnormalities. Then physically active people and those who are following healthy diet, they have a reduced risk of having endometrial cancer. Next slide, please. Over 90% of women with endometrial carcinoma, they present with abnormal vaginal bleeding. So they can have irregular perimenopausal or postmenopausal bleeding, irregular intermenstrual bleeding with anovulatory cycles. Rarely, abnormal endometrial cells are seen on a routine pap smear in asymptomatic postmenopausal women. Okay. Next slide. So how you evaluate a patient who is with irregular vaginal bleeding and she is on hormone replacement therapy? You look for this hormonal breakthrough bleeding. It is due to inadequate progesterone. It can be due to some polyps or a fibroid. It can be due to some hyperplasia or cancer. And very rightly, Dr. Manikam, you pointed out that you need an endometrial biopsy, which is the standard test for any abnormal vaginal bleeding. It is very sensitive for neoplasia, but it is not sensitive for polyps or fibroids. So in the recent talk, which came in 2021, they say that if a female is with risk factors and she's having thick endometrium, go for a hysteroscopy plus biopsy. But if there are no risk factors and only thick endometrium is found in a postmenopausal woman, then you can go for a pipple biopsy. Okay?
Okay.
So next slide, please. How you investigate? You just spoke about this one, hysteroscopy and biopsy. You have to talk about other things also. So always start from the basics, okay? So you have to do a complete blood count, coagulation, liver function, renal function, chest X-ray. Ultrasound was already done. Then you have to do a CA125. Then either you perform a pipple smear in low-risk females or you go for a hysteroscopy and directed biopsy. Okay, next slide. So as we know that there are different histopathological types of the endometrial cancer. They are macroscopically, it should be verified. Microscopically, it should be verified. There is endometrioid carcinoma, adenocarcinoma variants, which have squamous differentiation. No need to know all these things. This is just for part 2 stuff. Next slide. Again, next slide, please. So you have the histopathological grades like grade 0, where you cannot assess what grade it is, grade 0. Then well differentiated is grade 1. Grade 2 is moderately differentiated cells, and grade 3 is poorly or undifferentiated cells. Degree of differentiation of the adenocarcinoma is another basis for classifying carcinoma of the uterus, which is grouped as grade 1, where less than 5% of a non-squamous or non-modular solid growth pattern is seen. 6 to 50% in grade 2 of non-squamous or non-modular solid growth pattern, and in grade 3, more than 50% is the non-modular solid growth pattern. Then we follow the FIGO staging and the TNM classification is there. Next slide, please. This is FIGO staging. This is for the purpose of theory only. No need to remember it by heart, but you should know that what in stage 1, the tumor is confined only to the uterus, with the further stage 1A and 1B, half of myometrial invasion, less than half and more than half. Then in stage 2, the cervical stroma is involved. And then stage 3, the local and regional spread of the tumor is there. Stage 3 has further A, B, C, and C is again C1, C2. These are all details for theory purpose. No need to remember all these things in your clinical exam. Next slide. Again, there is TNM plus FIGO staging. Next slide, please. Then there is something called surgical staging procedure for the endometrial cancer. These all things are taken from the FIGO update in 2021. So these are very recent ones. Okay. So next slide, please. we'll come to the management treatment options. So stage 1, as I told you, this patient, because you reached till the end, Dr. Manikam, you didn't ask me anything. They stopped me and they said they will stop you and ask that, okay, what is your diagnosis? So then you will come with a differential diagnosis. Once you say differential diagnosis, they say, okay, this is endometrial cancer. Now, how will you manage the patient? Now you have to speak that, okay, the management depends on the stage of the disease. Then they will tell you this was stage 1 endometrial cancer. So you didn't ask anything, you didn't allow the examiner to talk.
Sorry, ma'am.
It's okay, because although you passed the station, you reached everything, you told everything, but you have to, ask questions and, go stepwise in a proper way. All right?
Yes, ma'am. Yes, ma'am.
So stage 1, you need a simple hysterectomy with bilateral salpingo-oophorectomy. Then they ask me, can you perform it laparoscopically? Yes, you can. If the expertise is available, you can proceed laparoscopically. Okay, this was also a question. But you already said you will go for laparoscopy, right? All right. Then in stage 2, there is either occult stage 2 disease. So you can do therapeutic management of patients with clinically occult stage 2 diseases similar to that as patients with stage 1 disease. So simple hysterectomy with BSO you will do. And if it is a clinically overt stage 2 disease, like macroscopic bulky stage is there, so you will perform a radical hysterectomy with bilateral salpingo-oophorectomy, lymphadenectomy, and selective aortic node dissection, which is can be used as a primary treatment. Next slide. Stage 3 patients, they are managed by complete surgical resection of all pelvic or nodal disease, followed by post-operative extended beam radiotherapy or chemotherapy. As primary tumors of both the ovary and endometrium may be present in the patient with presumed stage 3 disease with ethnic cell involvement, so full surgical staging is required. An expert pathological examination should be done. While in stage 4, the optimal management with the stage 4 endometrial cancer patients, it should be cytoreductive surgery, which is associated with superior overall survival outcome, especially when the metastatic sites are intra-abdominal, peritoneum or omentum. In advanced disease, neoadjuvant chemotherapy is also an option, particularly if post-operative morbidity is considered likely or ascites is present. Next slide. So there is some adjuvant treatment. Adjuvant radiation is required based on the stage of the disease, tumor type, and the presence of risk factors. So this is also one of the questions. Low risk disease, stage 1, grade 1 or 2 with no or superficial myometrial lesion, they don't require adjuvant therapy. Then the patients who are not willing for surgical treatment, they can be offered progesterone therapy. Although it was widely used in the past, but now it is not considered that much. It can still be considered for women who have prolonged remission of metastatic disease at grade 1 or this one who have this estrogen receptor or a progesterone receptor positive disease. They can get benefit with the progesterone therapy. Or the women who want to retain their uterus, like young female who wish to preserve their fertility, their progesterone therapy can be considered. And then final treatment is hysterectomy. Okay, next slide. Or there are people who are inoperable. So the most common reasons of endometrial carcinoma to be deemed medically inoperable for morbid obesity and severe cardiopulmonary diseases. In such cases, uterine brachytherapy is advised and has been shown to achieve cure rates of about 70%. This patient also fits into this bit in this category. She's very obese, okay, and she is having high blood pressure. So you have to evaluate her a little more before offering her this surgery. Okay, she can be a candidate for only brachytherapy. Then diagnosis in young women. Since endometrial cancer is uncommon in women younger than 40, diagnosis during the reproductive years should be made with caution, and grade 1 endometrial carcinoma may be confused with severe atypical hyperplasia. In these women, consideration should be given to an estrogen-related underlying condition such as granulosa cell tumor, PCOS, or obesity. The safety of fertility preservation is well documented in grade 1 endometrial cancer, which is not invading the myometrium, which is you do an MRI and you know that. Then progestins such as megestrol acetate or medroxyprogesterone acetate may be appropriate in young women. Next slide, please. All right, then they ask about the recurrence. The recurrence was if what you will do if there is a recurrence of the therapeutic management of localized recurrence includes surgery, radiation therapy, or a combination of both. Next slide. Follow-up, you already mentioned, Dr. Manikam, and very rightly, that the experts recommend close follow-up after the completion of treatment for endometrial cancer, particularly in the first 3 years after diagnosis, when the risk of the recurrence is highest. Okay, in the first 3 years, you have to follow them regularly. This includes what? History, physical examination every 3 to 6 months, and other tests like pap smears, blood tests, or CT scans or other scans may be required. If the cancer does not come back after 5 years, women can usually stop seeing the oncologist and return to their primary physicians. Women should call their doctor if they develop any symptoms of vaginal bleeding, pain in belly or pelvis, a cough that will not go away, or an unintentional weight loss. These could be signs of the cancer coming back. So this was also a question that how you will follow up the case and what you will tell the patient, because this is just stage 1 cancer. Okay, next slide. Yeah, we are done. Okay, so that's all for today. I would like you people to give me a feedback of how was the session, if it was beneficial for you people.